ICU care caused by human metapneumovirus in infants. I was the writer of the paper, and my colleagues were there to support me and help me with my work. Dr. Yulia Ivanovska, Dr. Gorica Popova, Dr. Katarina Bochkovska, Dr. Irina Chakalarovska, Dr. Mirjana Popovska, Dr. Vesna Jovicic, and we were a great team and worked together in getting this work done. So the introduction, the human metapneumovirus usually causes mild cold-like symptoms, but in infants, it can lead to serious problems like bronchiolitis and pneumonia. The human metapneumovirus is a negative sense single-stranded RNA virus of the family Pneumoviridae. It was isolated for the first time in 2001 in the Netherlands. It is the second most common cause after respiratory syncytial virus, RSV, of lower respiratory infections in young children. The peak age of hospitalization for infants with human metapneumovirus occurs between 6 and 12 months of age. A slightly older peak than with respiratory syncytial virus, which is at a younger age of 2 to 3 months. The clinical features and the severity of the human metapneumovirus are similar to those with the respiratory syncytial virus. This is what we observed. A human metapneumovirus is also an important cause of disease in older adults. The estimated incubation period is 3 to 6 days. Broader use of molecular diagnostic testing has increased identification and awareness of the human metapneumovirus as an important cause of upper and lower respiratory infections. The transmission of the virus is like other respiratory viruses, and the surveillance data from the CDC, the National Respiratory and Enteric Virus Surveillance System, shows that the human metapneumovirus to be most active during late winter and spring in temperate climates. The human metapneumovirus is most likely spread from an infected person to others through secretions from coughing and sneezing. Close personal contact is necessary for the virus to spread, such as touching or shaking hands, touching objects or surfaces that have the virus on them, then touching your mouth and nose and eyes. Human metapneumovirus circulates in distinct annual seasons. Its circulation begins in winter and lasts through spring, until and through spring. Human metapneumovirus, RSV-virus, and influenza can circulate simultaneously during the respiratory viral season. And this is a differential diagnostic challenge because everybody presenting in the hospital is sick and all these viruses are circulating at the same time in the communities. Our experience in the early spring of 2022, just as the pandemic with COVID was slowly stifling, we observed an increased number of hospitalized children under the age of 5 with severe pneumonia. These children required oxygen support and were with prolonged hospital stay of at least 2 weeks. We suspected that an invasive virus was circulating in the community, resulting in an increased number of cases of severe pneumonia in infants and children. Our aim was to identify the respiratory pathogen that may be responsible for such an increased number of sick children in our community. The method that we used, our study was a retrospective study, and we analyzed a total of 18 children under the age of 5, which were at the time hospitalized in our unit in a period of 1 month, from April 1st to April 30th, 2022. All of the patients were with an acute community-acquired pneumonia, and all of the patients had no other prehistory of chronic health issues, other than the standard laboratory and microbiological and imaging techniques for diagnosing pneumonia. All of the patients underwent a complete molecular respiratory RTQ PCR panel for 19 viruses and a multiplex PCR for 7 bacteria, which helped us with the diagnosis and the isolation of the virus. From our experience, in the next slides, I'm going to present 3 case reports of children that were hospitalized in our unit in April 2022, in which we isolated human metapneumovirus. In the spring of 2022, we had an increased number of sick children in our community with respiratory illnesses seeking ambulatory care, and as well as an increased number of children requiring hospitalization because of pneumonia. The hospital was working at full capacity, and our ambulance office was just full of children waiting to be checked. So the first case, as you can see here, is SA, an 11-month-old girl that resides in Skopje, the capital of Macedonia. This was her second stay in our hospital, and the previous hospitalization was in July 2021 with a discharge diagnosis of pneumonia. The time between hospitalizations, the baby was in good health. The current episode started 2 days before admittance with nasal secretions, high fever, and an intensive cough. After a chest x-ray was realized, she was admitted to the hospital. On admittance in the hospital, she was agitated, very agitated, pale. She was febrile, 38.5, with evident dyspnea and tachycardia. On auscultation, there was crackles and rales, more evident on the right. We did a standard laboratory analysis, microbiological testing, and imaging techniques for diagnosing pneumonia. And the complete molecular respiratory RT-qPCR panel for 19 viruses and multiplex PCR for 7 bacteria was taken, with a positive test result for metapneumovirus cycle CT 28.1. X-ray, as you can see, with lung consolidation observed on the right pericardial. The CRP was 50.5 milligrams per liter. On the second day after admittance, with the worsening of her condition, she was placed in the ICU with oxygen support with a mask that she needed for a duration of 4 days. She received IV antibiotics, third generation cephalosporin and methylprednisolone, as well as inhaled salbutamol. The 11-month-old girl was discharged with complete recovery on day 14. The second case report is NK, 9-month-old girl from the Skopje region. This is her first stay in our hospital. The current episode started 2 days before admittance and with nasal secretions, high fever, intensive cough. And after a chest x-ray was realized in the admittance office, she was admitted to the hospital. On admittance in the hospital, she was dehydrated, pale, febrile, 38.9, with evident dyspnea, tachycardia, and on auscultation, there were crackles and rales evident on the right and left side. As with all our children, we did standard laboratory, microbiological, and imaging techniques for diagnosing pneumonia and complete molecular RT-qPCR panel for 19 viruses and a multiplex PCR for 7 bacteria was taken with a positive result for metapneumovirus, CT 31.1. The X-ray was with lung consolidation observed on the right pericardial and left subhilar. The CPR was 30.2 milligrams per liter. This child as well, a couple of hours after admittance, was with worsening of her condition, and her oxygen saturation level in the blood was 87, 88 and lower, and she was placed on oxygen support with a mask that she needed for 5 days that she did well with. She received as well intravenous antibiotic, third generation cephalosporin, and methylprednisolone intravenous, as well as inhaled salbutamol. She was discharged with a complete recovery on day 12. The third case report was a little bit of an older child. It's SA, 3-year-old boy from the Skopje region. This boy also lived for 2 weeks of the month in Serbia because his mother was Serbian and his father was from Macedonia. So a couple of days before coming to Macedonia, he started with his sickness. This is his first stay in our hospital. He was previously a healthy boy with a few upper respiratory infections. 3 days before admittance, he was with nasal secretions, high fever, and intensive cough, and lower appetite. After a chest x-ray was realized, he was admitted to the hospital. On admittance in the hospital, he was dehydrated, pale, and febrile, 39.5, with evident dyspnea and tachycardia, and auscultation, there was crackles and rales on both sides. We did start laboratory analysis, microbiological and imaging techniques for diagnosing pneumonia with complete molecular respiratory RT-qPCR panel for 19 viruses and PCR for 7 bacteria. Was taken with a positive result for metapneumovirus, CT 26.96. X-ray was bilateral pericardial lung consolidation observed. CRP was 13.5, and the procalcitonin was 1.23 nanograms per milliliter. On the third day after his admittance, his situation worsened with his blood oxygen saturation lowering, and he was placed in the ICU with oxygen support with a mask that he needed for 5 days. He received IV antibiotics, third generation cephalosporin, as well as aminoglycoside and methylprednisolone, as well as inhaled salbutamol. He was discharged with complete recovery on day 14. So the results of our analysis, with the above mentioned method, adenovirus was isolated in 5 of the 18 children. Parainfluenza was isolated in 5 of the children, 27%. The human metapneumovirus was isolated in 4 patients, 22%. And the RSV in 4 patients, 22%. Bacteria Haemophilus influenza was found in 7 children, 39%. And Streptococcus pneumonia was found in 4 patients, 22%. 50% of the hospitalized children had mixed viral and bacterial infections. And all of the patients that had severe pneumonia at that moment in our unit, and required oxygen support, we isolated human metapneumovirus. So in conclusion, we concluded that the human metapneumovirus may be associated with worsening of the clinical and radiological outcomes of pneumonia in young children. So thank you very much for your attention. If anybody has any questions for me,